when we discussed with this patient regorafenib, we also discussed the recent results from the ReDOS trial, which is the regorafenib dose optimization study. And this study essentially was a study that was a large phase 2 randomized study ran through our accrue network. And it essentially was asking a simple question. When you go into the clinic, everyone was dosing regorafenib like it's the Wild West. Some, start at 160, others start at 120, others do 80 and go up. Others skip a week here or there, and there was no data. So we decided to go back and look at a study that tries to establish a strategy that helps us, do it in a more organized way for our patients. So the study was 2 arms, and one arm would be the 160, so the standard dose, and the other arm was the experimental arm. Patients would start at 80, go to 120, then to 160 on a weekly basis. So they'll be seen in clinic every week until we reach the maximal tolerated dose, and then they'll get their week break. And then whatever that dose was at the end of the dose escalation was the dose the patients will be on. And so that was the design of the study. The primary endpoint of the study was essentially a primary endpoint that combined the potential gain in efficacy alongside with the potential improvement in the toxicity profile. And this was essentially a primary endpoint that would include patients who would go through 2 cycles of therapy and then get their scan and proceed with cycle 3. So that study's primary endpoint was looking at a 15% improvement with the dose escalation strategy versus the 160. So when we concluded the study, we looked at the primary endpoint, and it was close to 20% improvement with the dose escalation strategy from 80 to 120 to 160. So this was a positive study. One of the intriguing findings of the study was also the survival was improved on the dose escalation strategy. So it was close to 9 months versus close to 6 months on the regorafenib 160. Now, interestingly, if you look historically at where regorafenib stands, and most agents in this, so TAS-102, regorafenib, even unselected cetuximab, those patients have a 6-month survival benefit. So it was very intriguing to us to see a 9-month in the experimental arm and a 6-month in what we call the standard arm, which was very consistent with the historical controls for this patient population. So this was a positive study for the primary endpoint with an interesting finding in overall survival. PFS was increased just by a little bit, 2 to 2.5 months, was not statistically significant. The toxicity profile was improved with the dose escalation strategy, especially in the first month of therapy, which is a very critical month in the life of these patients in the refractory setting. The quality of life of patients also seems to be preserved in the dose escalation strategy, and there was a loss in the 160 at 2 weeks specifically. There was a dip that readjusts with adjusting the dose. So overall, when we looked at this study, the study does suggest that a dose escalating strategy makes more sense for our patients, and in fact it should establish a new standard for our patients with metastatic colon cancer that are refractory. Now, in terms of also, we looked at another randomization into the study that looked at a preemptive strategy versus a reactive strategy with clopidogrel, with a hand and with essentially a steroid cream. We don't have the data yet fully analyzed. We will be hopefully presenting this at ASCO and ESMO GI. But the goal here was to see less hand and foot syndrome from hopefully from giving that steroid cream to patients. But what we've noticed is there were less severe hand and foot syndrome, at least in the first four weeks of treatment on the dose escalating strategy versus the standard 160 milligram strategy. So there's certainly an effect on hand and foot syndrome. That doesn't mean we're not seeing it. That means we're seeing it at a lesser and a lower rate, or a lesser rate and a lower grade. So that's overall, what we've seen from that study, and that's what led essentially to the choice of this treatment or dose escalation strategy for this patient. So the REVERSE study that we talked about a little bit, the REVERSE study really tried to inform us about whether we can move regorafenib ahead of EGFR inhibitors, whether patients had right or left-sided tumors. And that study was pretty intriguing. It's mostly hypothesis generating. We need to confirm that in the US. But what this study suggests is that regorafenib perhaps plays a more important role if it's moved a little bit up in the sequence of therapies rather than put it as a last-ditch effort. And that's consistent with what we've seen with Concur, where patients were treated, were less pretreated than, say, the CORRECT trial, which included mostly Western patient population. So the importance of this and its implications is that I think in my own clinic I'm having this discussion with a lot of patients, especially on the right side, RAS wild type like this patient. On the left side, I still favor moving EGFR inhibitors a little bit closer to second line. I haven't moved them completely to the first line yet. But on the right side, the RAS wild type, right-sided tumors, definitely would consider regorafenib as the first option before EGFR inhibitors based on the REVERSE study. Although the REVERSE study does suggest that the effect is equally good both on the right and the left side. From the practical standpoint, in my clinic, I do this primarily on the right side.